Good afternoon, everybody. I'm a pediatric neurologist and epileptologist, so I don't deal with your DHCA on the table, and I'm essentially called to deal with the aftermaths of what you have done or you haven't done, or the surgeon hasn't done. We know that in last couple of decades, the worldwide scenario of congenital heart disease has changed. There are surgical advances, the perioperative care is improving, the survivals are improving, the complexity of congenital heart that is being operated, that is also increasing. When we look at the Indian scenario, and there was a paper several years ago where they identified that about 180,000 children each year were born with congenital heart, and about half of them were in the need of early intervention. But when you look at how many surgeries were being done at that time, only about 6,500 surgeries for congenital heart across all the ranges, and only a small proportion in neonates and young infants. And so essentially less than 2% of infants with congenital heart were getting optimal attention, and that was 15 years ago, or 10 years ago. So essentially, I hope that the situation has changed and more children are getting operated now, though I haven't got any up-to-date data that how many children are being operated across the nation. Acute post-operative events, particularly neurologically, they can be of a variety of natures. Seizures and electrographic seizures were already mentioned, and I'll come to that in slightly later. So the seizures can be clinical and electrographic, and it is important to assess whatever abnormal movements you are seeing, whether they are genuine seizures or not. Strokes are common, and they can be embolic events because of air embolism, particularly with your cardiopulmonary bypass, or they can be particulate embolism. You can have dissection of vessels, and then you have the issue of venous thrombosis. And identification and management of these neurological events is going to be quite challenging because, again, you have to think very carefully whether you are going to anticoagulate a child who has got dissection or venous thrombosis against the consequences of anticoagulation and the reversibility and the likelihood of second surgery and the bleeding and whatnot. Cerebral bleed is also one of the complications. Movement disorders, spinal cord injuries, particularly with aortic surgeries, that can lead to spinal cord or spinal vessels obstruction. And critical care neuropathy, so longer the patient is in intensive care, has got sepsis, longer the ventilation time, the use of paralyzing agents, higher is the risk of critical care neuropathy. And there's good data to suggest that your long-term neurological outcome is also related to your length of stay. And then obviously, if you had critical care neuropathy, you're going to have difficulties in extubating this child off the ventilator, starting the right physiotherapy, and the neurological consequences are going to change as well. Obviously, this is all related to a variety of physiological variables because with congenital heart, you are essentially dealing with extremes of physiological measures, really, whether it is circulatory arrest or hypothermic arrest or bypass or whatever it is. And you have issues about the homeostasis, so you need to have acid-base balance and the risk of acidosis. That's again quite closely related to your long-term neurological outcome, and there is good evidence to indicate that post-operative elevated lactate or lactic acidosis is associated with abnormal neurology subsequently. And these are the typical lesions that are highly relevant in terms of the neurological insults to the children. So transposition, aortic lesions, obstructive lesions. So what are the different mechanisms that are associated with these? So there is one argument that some of the lesions are duct dependent, such as transposition. And so when the duct is closing, you essentially end up having hypoxic or brain injury and acidosis. So if you knew that they have a duct dependent lesions, you could do something about them. Cardiopulmonary bypass and embolism associated with that, and the cardiopulmonary bypass being associated with profound systemic inflammation and the cytokine storm, which is quite neurotoxic. So if you can manage that, then you might be able to modify the neurological injury in the children. There is good evidence to indicate that the cognitive impairment happens even in adults who have got cardiopulmonary bypass. And about 80% of adults in the first couple of months of their cardiopulmonary bypass do show evidence of cognitive impairment. I suspect it's not formally analyzed regularly in the clinical practice. And when these adults are actually evaluated anywhere from 2 months to 12 months since their bypass surgery, 40% still have residual cognitive difficulties after their bypass. So that is a risk factor for cognitive impairment, and that applies to both adults and children. Hypothermic arrest, we already heard quite a lot about that, and I don't thank Dr. Patil for using the paper that I was going to quote. But this is Boston Circulatory Arrest Group, where 171 infants had comparison of their neurological outcomes between bypass versus DHCA. And the DHCA was associated with high risk of electrographic seizures, high risk of clinical seizures, and longer time for the EEG to recover after they had seizures. And that magic figure of the duration of hypothermic arrest was 41 minutes, but I understand it is very dependent on how low you go as to your level of tolerability and how quick your surgery is, I guess. The Boston group, they compared this, and they looked at these outcome of the children at 1 year, 4 years, and 8 years. And at 1 year, they all had low psychomotor and mental development. So your psychomotor development is your motor milestones, your gross motor milestones, your fine motor milestones, while your mental developmental score includes your speech and language development, your early concept of numbers, your executive functioning, your memory. So essentially cognitive aspect and the more advanced aspects such as speech and language impairment. And there was close correlation between the post-operative seizures to abnormal MRI and abnormal neurological findings in the children. Similarly, at 4 years of age, they had deficiencies in their motor milestones or motor functioning. The IQ itself wasn't changed, but importantly, they identified that there was a significant impact of the socioeconomic status on the executive functioning at 4 years of age. And I think that is quite a relevant factor for the Indian population. And one factor that you will come to know later on, they also looked at the maternal education, and the maternal education seemed to be quite closely correlated to the neurological outcome. And it's quite interesting actually, because there are lots of studies, not just related to cardiac functioning or cardiac or neurological outcome, but overall neurodevelopmental status of children is highly dependent on, on maternal education and maternal IQ actually. And I think that's quite a relevant factor for the Indian population. At the 8 year of age, again, they identified that there are no change between the groups for IQ, but subtle learning difficulties, specific learning difficulties, social communication disorders, they take all the priority at this time, that all have relevance. So your just IQ is not enough to do well at school or get your science grades. There are lots of other issues that need to go right for anybody to perform well, really. The other mechanisms include hypoperfusion during the separation from the bypass, hemodilution, and I think we heard a word or two about hemodilution and hematocrit. The data about whether you should have hemodilution or not is not really clear. There are some studies that indicate that hemodilution may be beneficial because then you reduce the viscosity of the blood, while some data suggest that you might be compromising your cerebral perfusion if you are too hemodilated. And then length of stay I already alluded to. Seizures are common, and that's what I do day in and day out. Usually they represent CNS insult, but you also need to recognize that seizures can be because of metabolic disturbances. So once you have concluded that this is not hypoglycemia, hyponatremia, hypomagnesemia, hypocalcemia, and the seizure is not symptomatic of those metabolic aberrations, then usually these represent a CNS insult. Now, this is a study that my colleague Penny Fallon, they published 20 years ago. They looked at 523 patients, and they identified 31 patients having neurological complications, so about 8%, and half of them actually had epileptic seizures. And 20 out of 24 children had abnormal EEG. Similarly, 2 to 25% USA data indicated abnormal neurological events in the children, and a significant chunk of them being epileptic seizures. The clinical management of seizures starts with your identification of the seizures, and not every seizure will jerk, so you need to identify what the seizure looks like and take an opinion rather than thinking that everything that happens with the child, any funny do that happens, is actually a seizure. The treatment I would propose that go along with the APLS algorithm as to what you need to do. The Boston DHCA group again looked at 136 neonates and infants, and 20% had seizures. More recent study looked at 178 neonates, and again 11% had electrographic seizures. So even with time, the proportion of children who have seizures post-operatively hasn't changed an awful lot, really. There was some evidence that at 4 years, that presence of seizures post-operatively did not seem to influence the IQ, but they had difficulties in executive functioning and social skills, so presence of seizures. So there are some ideas as to how you could neuroprotect, and again, some of the ideas have already been discussed before. One is that whether you could use modified ultrafiltration and peritoneal dialysis early, and that is essentially to improve your brain metabolism and perhaps wash out your toxic cytokines that you will generate in your deep circulatory arrest because of the systemic inflammatory response. Acid-base balance, I already told you that there is evidence that post-operative persistent lactic acidosis is a risk factor for abnormal neurology. Degree of cooling and rewarming, and that affects your inflammatory response, but again, there is not a very good data. The data is conflicting whether you should do a gradual rewarming or not, and I think you guys are more expert in that than I am. Maintaining adequate cardiac output, again, you guys are more expert whether keeping your chest open and using ECMO to maintain adequate cerebral perfusion. But from the neurological point of view, again, these strategies have already been discussed, whether you can non-invasively monitor cerebral blood flow by using transcranial Dopplers, jugular saturations, and continuous amplitude integrated EEG to detect electrographic seizures. Now, I can understand that some of these strategies are quite invasive, particularly without saying that that is an important part in optimizing your neurological outcomes. Now, watch this video, please. There's no volume, actually. Any takers? What are we seeing here? How many of you think that this is a seizure? A few? How many of you think that this is not a seizure? Most are non-committal, sitting on the fence. So this is a child who has got essentially right-sided, I can run the video again, so I've got a dystonic and athetoid posturing distally. If you watch the right hand carefully, there's a lot of dystonic and athetoid posturing, and similarly with the leg, your leg is flexed in and the child is distressed. So this is not a seizure, and I think you need someone to kind of look at this if you are in doubt, because if you treat this child with anti-epilepsy medication, you could actually precipitate a movement disorder. So this is a child with post-operative encephalopathy with chorea, what used to be called or is still called post-pump chorea. Now this is a distinct neurological entity that was described 50 years ago in 1961, and the encephalopathy can be of variable degree. It can be mild or severe. And the typical risk factors that are associated with this are essentially hypothermic arrest, CPB, and then your changes in metabolic profile, particularly with PCO2 and acidosis, and that would alter your cerebral circulation. There is some suggestions whether older children are more prone to have this than younger children, but I think that hasn't been a robustly corroborated observations at all. The possible mechanism, one mechanism that they have postulated is that basically with the changes in the cerebral perfusion, some degree of hemostasis. You might be altering the deformability of your red blood cells, and the red blood cells become a bit acanthocytic, and then they get hemolyzed, and then that hyperbilirubinemia or hemolysis will lead to changes in basal ganglia. So very similar to you expect in Kernicterus in newborn babies, and that is one of the proposed mechanisms. The long-term outcomes depends on the degree of encephalopathy. This American group looked at about 36 children who had post-pump chorea over 7 years of time. And you can see good, very high mortality. 8 of them died. And because the reason that they die is because of the respiratory complication, but also a lot of energy expenditure in these abnormal movements, and they need to be contained really. And also caloric restriction or caloric reduction, that might actually give more mortality because nutrition is very important in these children. So out of 15 that they chased the long-term outcome for, interestingly, one of those 15 actually did not have a circulatory arrest or hypothermic arrest, but it was a SVT child that was treated with hypothermia, and despite that, child developed actually post-pump chorea. Whether you call it post-pump chorea or not, I'm not sure. So 14 out of them actually had cardiac surgery with bypass time up to 150 minutes, and 12 had up to 62 minutes of DHCA. So their outcome was pretty grave. A significant chunk had neurobehavioral comorbidities such as ADHD, expressive and language impairment, social communication disorder, low IQ, and persistent dyskinesia. So they must have had significant component of very severe encephalopathy. So I think it's an important condition to recognize and also counsel to the family related to your pump. Most important message here is not everything that jerks is a seizure, because I think there were a handful of people who thought that was a seizure, but it wasn't a seizure. So not every seizure jerks, and not everything that jerks is a seizure. So please remember that. So neurodevelopmental disabilities are one of the commonest and damaging consequences of congenital heart and the surgery itself. And there is good evidence over the years that operated infants show impairments in their reasoning, their learning, their executive functioning, their social communication, not just IQ. And IQ is not everything, as I have already told you. This is a classification that you all are familiar with. So essentially it's the gradation of your cardiac disease based on perioperative mortality, and essentially divided between single ventricle and two ventricles associated with or without your aortic arch obstruction. So I think it's intuitive that class 4 is one of the most severe category of your cardiac lesion. And so this group, International Cardiac Collaborator on Neurodevelopmental Group, so it's quite a large data. 6 countries participated, 22 institutions, and nearly 1,800 children. And the data is over 21 years, from 88 to 2009. And all these children were operated under the age of 9 months with bypass. And their neurodevelopment was analyzed a couple of years down the line. They used a Bailey scale, and there is some issue that Bailey scale may not be an optimal tool to use actually. Because it might underestimate your neurological morbidities. So in fact, you might have more morbidity that you cannot really measure with Bailey scale. They also looked at whether the children had other genetic or suspected genetic abnormalities and any extracardiac major abnormalities. So what they looked at, that all the children who were operated at young age with bypass, they had lower than normative means in their psychomotor as well as mental developmental quotient. And later years of birth, you would expect intuitively that as the surgical techniques got better, you might get less of that gap between normal and the affected children with time, and that didn't seem to happen. So essentially, later year of birth and later surgery in sort of towards 2000 was not associated with any better results. So whether you were actually getting more complex children and that diluted the effect of better surgical techniques, that is unclear. But there may be other factors that may be more relevant, and then maternal IQ or maternal education and socioeconomic status then stood out quite highly in the relevance to the IQ or the developmental outcome of the children. Obviously, it's intuitive that if you will have low mental abilities, especially if you had other genetic or extracardiac abnormalities, but maternal education stands in there as well. So your cognitive development is dependent on that. So this is one of the most recent studies that I have come across. This is an Australian study, and they call it Hearts and Mind study. And this is a prospective study where they enrolled infants with congenital heart disease and followed them up and had their 2-year assessment. But again, they used the Bailey scale actually. So 128 of these children had cardiopulmonary bypass, 84% had prostaglandin infusion, 13% died before 2 years of age, and out of 130, most of them had impairment in composite language, cognitive or motor scores actually. And at least a third of them had impairment in at least one of those domains, and 9% had a severe impairment in at least one of those domains. So I think it's established that this is associated with significant morbidity, neurobehavioral morbidity in children with congenital heart. And again, that's a sort of typical risk group that they identified that is associated with problems. Now, somebody already said that some of the children may have abnormal brain development early on, and they have higher prevalence of cerebral dysgenesis. They have abnormal brain volumes, maturation, metabolism, cortical structural malformation. So if you look at this scan, this child has got pretty extensive bilateral polymicrogyria. So whatever you do, their neurological outcome is always going to be quite guarded, and that needs to be assessed first. And so I'm absolutely up that these children should have a careful neurological assessment before, and all children should have pre-operative MRI to identify any structural abnormalities. Because in this particular child, the brain just hasn't been put together correctly. So this child is always going to have problem, regardless of whether they have congenital heart, operated, not operated, whatever. They also have white matter abnormalities preoperatively, and there is good evidence to indicate that even people who do not have structural abnormalities identified, they seem to have persistent low volumes of their brain even when they grow into adulthood. So that is all going to have consequences for your educational attainments and neurobehavioral comorbidities. There are many genetic syndromes that are associated with cardiac lesions. I don't need to go to the list of that, but the bottom one, the genetic polymorphisms. So genetic polymorphisms are known to occur in about 10% of patients with cardiac problems, and particular polymorphism that is associated with apolipoprotein E. And this is a compound which is highly relevant for your neuronal repair, whether it is cardiac surgery, whether it is stroke, whether it is traumatic brain injury. So this is a compound that is quite important. So if you had a polymorphism in this particular component, whether that actually makes you more vulnerable to have neurological impairment and neurological insults, because your neuronal repair mechanisms after an insult, this particular mechanism component that you more able to have impairment insult your repair mechanism after an component that actually you more able to have impairment and insult your neural repair mechanism after this particular component wasn't a that actually you more able to have impairment insult wasn't a your neural repair mechanism after wasn't a component that actually you more able to have impairment and insult your neural repair mechanism after this particular component that actually you more able to have impairment and insult your neural repair mechanism and this particular component that actually you more able to have impairment and insult your neural repair mechanism after this particular component that actually you more able to have impairment and insult your neural repair mechanism this particular component that actually you more impairment and insult your neural repair mechanism that more able to have insult your neural repair mechanism after this particular that more able to have insult your neural repair mechanism this particular after that actually more able to have insult your neural repair mechanism this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after this particular component that actually tumor people to have impairment and insult your neural repair mechanism this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after this particular component that actually tumor people to have impairment and insult your neural repair mechanism this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after this particular component that actually tumor people to have impairment and insult your neural repair mechanism this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after insult this particular component insult that actually tumor insult people to have insult insult your neural repair mechanism insult this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after this particular component that actually tumor people to have impairment insult your neural repair mechanism this particular component in about that actually in about tumor in about people to have in about impairment and in about insult in about your neural in about repair mechanism in about after in about this particular them that actually them tumor them people to have them impairment them insult them your neural them repair mechanism this particular brain that actually brain tumor brain people to have brain impairment and brain insult brain your neural brain repair mechanism after brain this particular operative that actually operative tumor operative to have operative impairment operative insult operative your neural operative repair operative this particular operative component that actually the brain tumor the brain to have physical impairment and the brain insult your neural the brain repair the brain after this particular component have a tumor have people to have a impairment have a insult have a your neural have a repair have a this particular have a component that actually tumor people to have physical impairment and insult your neural repair after this particular component that actually tumor people to have impairment and insult your neural repair this particular component that actually tumor people to have physical impairment and insult your neural repair after this particular component that actually tumor people to have impairment and insult your neural repair this particular component that actually tumor people to have physical impairment and insult your neural repair after this particular component that actually tumor people to have impairment and insult your neural repair this particular component that actually tumor people to have physical impairment and insult your neural repair after this particular component that actually tumor people to have impairment and insult your neural repair this particular component that actually tumor people to have impairment and insult repair this particular component that actually tumor impairment your neural repair this particular component that actually tumor people to have physical impairment and insult your neural repair after this particular that actually that tumor impairment your neural repair this particular component that actually tumor people to have physical impairment and insult your neural repair mechanism after this particular that action tumor elements your neural havoc repair mechanism this particular havoc component havoc that action havoc tumor havoc to havoc element havoc insert havoc your neural repair mechanism after this particular that action tumor elements your neural repair mechanism this particular component that action tumor to element insert your neural repair mechanism after this particular that action tumor elements your neural repair mechanism this particular component that action tumor to element insert your neural repair mechanism after this particular that action tumor elements your neural repair mechanism this particular component that action tumor to element insert your neural repair mechanism after this particular that action tumor elements your neural repair mechanism this particular component that action tumor to element insert your neural repair mechanism after this particular that action tumor elements your neural repair mechanism this particular component that action tumor